interviewing Dr. Robert Delcanho, an internationally recognized authority on TMJ and orofacial pain. I'm sure some of you are asking, what on earth has this got to do with my tinnitus? So, as a clinical audiologist specializing in tinnitus, I always teach my patients that tinnitus is an experience of noise in the ears and or head region, which isn't just about the auditory structures. There are many influencing factors in tinnitus, in why it manifests in our bodies. So TMJ or TMD, which we'll define further with Dr. Delcanho, is one of those factors. So I really hope you enjoy this interview. I think it's incredibly valuable, and I think it'll make you assess yourself and perhaps seek treatment for this in managing your tinnitus if you do have some of these symptoms that we discussed today. Okay, I hope you enjoy it. Thanks for watching. Dr. Delcanho, thank you so much for joining us here today and explaining the connection between TMJ issues and tinnitus.
Thank you for having me. Thanks for the invitation.
So for people who don't know what TMJ stands for, can you briefly describe what that is?
Okay, so the TMJ, T stands for temporal, which is the temporal bone of the skull. M is for mandible, which is the proper anatomical name for the jaw. And J stands for joint. So it means temporomandibular joint, or TMJ. It's the jaw joint, which sits right in front of your ear and allows your jaw to open and close and for you to chew and move your jaw around and eat and speak. So it's a very important joint.
Okay, so what's the difference between the actual joint, TMJ, and then the acronym TMD? Because I've read there are differences there. What do they?
TMJ is the joint. It's the anatomical name for the joint, right?
Okay.
So TMD means temporomandibular disorders. So that's a group of conditions that affect the TMJ and the related structures. So people often get a little bit confused and they come in and they see me and they say, "Oh, doctor, I've got TMJ." Well, that's sort of like someone saying, "I've got knee." TMJ is the joint, okay? So TMDs are the conditions that affect the joint and the related jaw muscles and ligaments and other structures.
All right, fantastic. So what are the common symptoms of TMJ disorders or TMD?
Yeah. Well, it's a group of conditions and they have things in common. So the most common one is pain in the region of the joint. So pain just in front of your ear and around the jaw is the most common symptom of a TMD, okay? And the pain is aggravated by movement or use of your jaw. So opening your mouth like to yawn or to take a bite of an apple or chewing upon your food aggravates the pain. So you've got pain in front of the ear that is aggravated by jaw movement or jaw function, okay? Some of the other symptoms are noises in the jaw joint. So this joint sits right in front of your ear. So if there's a noise coming from that joint, because it's next to your ear, you're very likely to hear it. So I often say to people who come in and say, "Oh, doctor, I've got noises in my jaw joint and in my ear." I say, "Well, that jaw joint sits right there. And if your knee was next to your ear, you'd probably hear some noise when you moved it as well." But anyway, it's a common symptom of TMDs is a clicking jaw joint, clicking noise, click, click. And sometimes it gets grating like sandpaper. We call that crepitus is the proper term for it. So there's pain with jaw function, there's noises. The other symptoms are people have trouble moving their jaw. They can't open their mouth or use their jaw easily. So there's like restriction. You can't open your jaw fully, or there's an interference to your ability to move your jaw easily and comfortably. So that's another symptom. And there are ear symptoms as well, which is sort of the basis of this interview, because it's right next to the ear and it shares structures. People often come in with ear-related symptoms, and I see patients from ear, nose and throat specialists and sometimes audiologists where people have gone in complaining of these symptoms and the ear tests normal, or their tests are normal. The ear canal looks normal. And in fact, the problem is possibly coming from the TMJ itself. So they're the common symptoms. The other one is headache. A lot of these patients have headaches, quite commonly in the temporal region of the skull. And they come in and they say, "Oh, doctor, when I wake up in the morning, I've got a headache." And that can be because the jaw has been overused during the night from tooth clenching or grinding their teeth in their sleep.
So could I ask, now, when do we consider it an issue, a bad enough issue to come and see someone like yourself? Because say if I have a bit of an ache or a jaw pain, or perhaps maybe one day it's a little bit clicky and then I just leave it alone, versus someone that has that for a week or months, of course, but what is the clinical time to address it?
Well, I'll say a lot. I would say most. A lot of symptoms self-resolve. Okay. So you might bite very heavily on a French baguette or something like that.
Yes.
And develop a bit of a click in your jaw and maybe a little bit of soreness. And usually that will self-resolve. It's like a sprain injury. It'll self-resolve over a week or two, right? But if it's more severe and troublesome, impacting on your life and persistent, then obviously one should get it further assessed. So there's no specific, after 2 days you go and see a doctor. I would say if it's persistent and troublesome, then definitely go and seek care.
Okay, so with the percentage of people that you see, how many actually have tinnitus? What's the ratio? Is it quite common?
Well, it's common. To be honest, I haven't actually sat down and figured out what the exact percentage is. But I do see patients, and tinnitus, like I've mentioned, ear symptoms, is one of the symptoms that I see, and it's quite common. Okay. And studies show that patients with TMDs, tinnitus is quite a common finding, a common complaint of the patient. I'm sorry I can't put an exact figure on it.
No, not at all. So it's just a rough guideline, but it is something that when I treat people with tinnitus, they are often unaware of the fact that tinnitus isn't just an ear issue. It can be related to so many other things. So it's really good to hear from someone like yourself the fact that it is quite a common thing.
Right. Well, patients are sent to me for their jaw. It's unusual. It does happen just purely for tinnitus, but usually for jaw problem. And tinnitus is amongst the symptoms that they have. So a good percentage of patients with jaw pain, TMDs, problems with their TMJs, have tinnitus, and it can be quite severe. But the whole thing is to determine whether that patient with tinnitus has those symptoms of TMDs that I mentioned. Because if they haven't got any TMD symptoms, it's unlikely that TMD is the cause of the tinnitus.
Yes, exactly. So what's the typical treatment plan that you implement?
For a TMJ pain?
For a TMJ disorder. So someone with, well, of course, even if they have tinnitus, it depends on what issue they actually are having with their jaw alignment. But is there, what are some treatment options that you implement for patients?
Okay, well, number one is pain control. So if someone comes in and they've got jaw pain, my first priority is to reduce the pain, okay? So that can be done with analgesics, painkillers. It can be done with anti-inflammatory medications. I tell patients to put hot packs or cold packs on their jaw, whichever they prefer. Sometimes I get them to rub some anti-inflammatory gel into the affected area. They have to go on a very soft diet because chewing force aggravates the pain, as I mentioned before. So you're going to be on a very soft diet, like soup or fish or something like that. Nothing that involves chewing force. And I tell patients, do not clench your teeth. Always keep your teeth apart because clenching the teeth loads the joint. Now, during the day, you can say, sit to yourself, keep your teeth apart, relax your jaw. But during the night, if I think patients are clenching their teeth or grinding their teeth in their sleep, I'll fit them with a special mouth guard called a splint. So it basically stops people grinding their teeth hard. And reduces loading forces on the jaw. So I use the analogy, if you sprained or injured your knee badly, you'd use crutches. So this splint, this mouth guard, is like the crutch for the jaw. And wearing those and doing those other things are often helpful. So patients can do other things like see physiotherapists and have ultrasound and laser and simple reversible type treatments, and usually quite effective.
So what's the time frame that we're looking at in terms of, so I say I come to you, I have tinnitus, and you say to me, you actually have TMD, this is what we're going to do, we're going to put in a splint. I'm going to be pretty hopeful that my tinnitus is going to go away.
Yeah.
But what is the reality here? What do you tell patients in terms of expectations?
Well, for the patients with tinnitus, Marie-Chantal, I never make promises, okay? I'm not going to say to a patient, I'm going to fit you with a splint. I'm going to do this, that, and the other, give you an anti-inflammatory, and you've got to go on a soft diet, and that is going to cure your tinnitus, because I think that's nonsense to do that.
Yes.
What I do say to patients is, you've got a TMJ problem, we'll treat the TMJ problem, and I hope that this will reduce your tinnitus. And studies have shown that patients who have jaw problems that are successfully managed, those patients show a reduction in their tinnitus. So I try and offer them some hope, but I can't make a promise to a patient that, I think that's
absolutely, because as I said, tinnitus is
very difficult.
There are so many influencing factors in tinnitus, but so everyone has to be really quite realistic.
So it's an interesting.
Go ahead.
I was going to say it's an interesting correlation, because patients who have chronic TMD pain, there are often other factors like you're talking about. So there are central nervous system factors, there are psychosocial factors, it's chronic pain type factors that we're talking about. And they really intermingle very closely with patients who have severe tinnitus. They have very similar type problems.
So would you ever say that there is a risk of tinnitus increasing after treatment?
I wouldn't expect that to happen. I wouldn't expect that to happen unless there are other factors. So if the tinnitus is totally unrelated.
Yes. Okay, good. I just have to put that out there just because this is a common question again.
When the patient enters a period of severe stress, exams coming up, divorce, financial issues, in these COVID times, they can increase your tinnitus just like they can increase your TMD symptoms.
Absolutely. So can you share a success story of a patient with tinnitus that you've treated? Do you have one?
Oh, well, I've had patients who've tinnitus has been improved, but I mean, really along the lines we're talking, patients have come in and they've seen an ear, nose and throat specialist. All the studies have shown, of that patient, they've had MR scans, they've had the nasal endoscopy, they've had their ears tested, the audiology, the whole thing, with fairly normal findings, including hearing. So that's an important finding with tinnitus patients, as you know. And it turns out that they've got a bad jaw problem, and they've responded well, and their tinnitus is markedly improved. So it has happened in my experience, but I never get extremely promising to a patient, as I've said before.
Yeah, absolutely.
Yeah.
So now this is a question that we didn't prepare for at all, but I'm curious, what made you select this field to specialize in?
Yeah, that's a good question. So I graduated in dentistry back in the Stone Age, 1978, I think it was. And I went into private practice, and a patient, there was one specific patient that came in, and I really didn't know how to handle it, because we hadn't really been taught in dental school properly how to handle these patients with jaw pain or orofacial pain in general. Yes. And we'd been taught what limited we had been taught was largely related to looking at how patients' bites were. So the concept was that a bad bite, if it's a terrible term, was the cause of the jaw problem. And it sort of never really made sense to me. And, I tried treating this patient according to the way that I'd been taught in dental school, with a bite change and a bite splint, and they weren't getting any better. So I thought, this is really interesting. And so I started attending courses wherever I could, learning more about it, and got more and more interested in chronic pain. And I ended up in the United States for a couple of years and working in a pain clinic. And, I guess it went from there. So when I came back to Australia, I just limited my practice to TMJ problems and orofacial pain. And then later on, I got into sleep stuff as well. So yeah, it was just really to me, it was an interesting area of dentistry, that really no one else was doing. So I guess I saw a bit of a niche possibility there, to get away from general practice.
Because as I was reviewing all of your achievements, as I said to you when we first spoke, I really don't know if you get any sleep at all, because you've got such a wealth of experience, and you've done many, many things in this field. So I thank you again for your time for the time that you've given to us today. And I'm sure that so many people watching will get some value from what you've shared.
Great. It's been a pleasure. Thank you very much.